Welcome back to MLT 130. Today, this is part 2 of the liver lecture, and we're going to be discussing specific liver disorders. The first condition we're going to discuss is Gilbert syndrome. This is the least serious of the inherited unconjugated hypobilirubinemia conditions. It is usually seen in males. The UDP glucuronal transferase is only about 30% of the normal amount due to a mutation of the gene. The category of jaundice you see is hepatic jaundice because the condition is affecting the liver itself. It is a problem involving the active transport of the bilirubin through the hepatocyte membrane to the microsomal region. And that's referring to the area in the liver cells where the enzyme UPD is located. In Gilbert syndrome, serum unconjugated bilirubin is only slightly elevated. This is usually a benign condition and no treatment is required. Next up is Crigler-Najjar syndrome. This is a rare condition. It is inherited. You have a decreased or an absolute lack of the UPD glucuronal transferase. Patients with type 1, the central nervous system type, die within 1 year because of irreversible brain damage and kernicterus. Type 2 is a milder form. You have no symptoms other than jaundice. In lab results, you will see a marked increase in unconjugated bilirubin in blood results. So here's a couple images showing a comparison of a normal patient versus a patient that's suffering from Crigler-Najjar syndrome. So let's first look at the normal patient. Okay, so you have the blood that's coming into the liver, and of course the bilirubin coming in is unconjugated. But in the liver, the bilirubin becomes conjugated with the help of that enzyme UDP. So we can see the enzyme is present right here. So this is our normal patient. But if you look down here, same process, it's the bilirubin is coming to the patient unconjugated, and it needs to be conjugated in the liver. But here you have an absence of the enzyme. So that bilirubin is never going to be able to become conjugated and become water soluble. So what did we learn about unconjugated bilirubin? It loves to go to nervous tissues, especially to the brain. So that unconjugated bilirubin is going to travel up to the brain tissue, and it's going to damage the brain tissue. And that's exactly what happens in this syndrome in a patient with Crigler-Najjar syndrome. Next, we have Dubin-Johnson syndrome. This is an impaired biliary excretion of conjugated bilirubin due to a gene mutation. This is a milder disorder. This is a form of hepatic jaundice. Let's look over here to the right at the diagram. You have a hepatic cell, so you have your liver cell, and you have your bilirubin, your conjugated bilirubin that's trying to move down into your bile caniculi or your bile duct. And you see the X here, and that conjugated bilirubin cannot be secreted into that bile caniculi or duct. So that's what's happening in Dubin-Johnson syndrome. So there's an impaired biliary excretion. So what are we going to see in our lab results for Dubin-Johnson? We're going to see increased conjugated bilirubin in blood and positive bilirubin in the urine as well. Why? We're going to see increased conjugated bilirubin similar to post-hepatic jaundice. It's due to a liver condition, so that's why it's classified as a hepatic jaundice. We will have backup of bilirubin, which is conjugated into the sinusoids. Thus, we have an overflow into the blood of conjugated bilirubin, so we will also see it in the urine. Next up is Rotor syndrome. This is a gene mutation that leads to bilirubin not being taken up efficiently by the liver and removed by the body, results in a hepatic jaundice. This is a benign condition and it's very similar to the Dubin-Johnson syndrome. So let's look over here to the right at our diagram. We have the bilirubin and we have the hepatocyte, which is representing our liver cells. So you have the X representing the bilirubin not being able to be taken up by the liver. And the reason the hepatocyte or the liver cells cannot take up the bilirubin like it's supposed to is because of a gene mutation. As far as lab results for Rotor syndrome, we will see an increase in conjugated bilirubin in blood, and we will also see bilirubin present in urine samples. Two other conditions that causes hepatic jaundice is Reye syndrome and toxic hepatitis. We spoke about Reye syndrome a little bit in the past. This is when a child has had a previous viral infection and they've taken aspirin and they end up with a hepatic destruction or liver damage, and you will have increased ammonia in the patient. For toxic hepatitis, this is caused typically from ingestion of drugs and their metabolites. An example of a drug would be acetaminophen, or commonly known as Tylenol. Certain drugs can cause liver damage because liver is our detox organ. More hepatic jaundice conditions include viral hepatitis. There's A, B, C, D, and E, and we'll be talking more in detail about those coming up in part 3 of the liver lecture. But let's go on and talk about alcoholic liver diseases. This is where there's hepatic injury from long-term consumption of alcohol. There's also cirrhosis. This is a result of chronic scarring of liver tissue, turning into nodules. It can be due to alcoholism or other long-term liver conditions. So let's talk about what happens in viral and toxic hepatitis and cirrhosis. In those conditions, there's damage to the cells and they lose their ability to conjugate bilirubin. Also, there's damage to the cells and they lose their ability to transport conjugated bilirubin to bile. This is where bilirubin leaves the liver and enters the intestines. As these disorders progress, the levels of unconjugated bilirubin increase. You can also see an increase in conjugated bilirubin. Although not as great, it's due to the leakage of conjugated bilirubin from damaged liver cells into blood circulation. So here's a question. Which of the following characterizes hepatic dysfunction in the early stages of viral hepatitis? Take your time, read all the options, try to answer it on your own before you move on and get the correct answer. The correct answer is B, elevation in the serum unconjugated bilirubin fraction. So now let's talk about some testing methods for bilirubin. Some classic methods were the Ehrlich and the von den Baer. Later methods include the Malloy and the Evelyn, but the current method is the Jendrassik and the Groff. It measures the total bilirubin. It cannot measure directly unconjugated bilirubin. It is calculated. Remember, our direct or conjugated bilirubin is water soluble, and our indirect bilirubin or our unconjugated bilirubin is not water soluble. The method that we use for newborns is direct spectrophotometric because newborn bilirubins run higher than adults. Something really important to remember about our bilirubin specimens is that we need to store them in the dark. Remember, UV light breaks down bilirubin. Remember when we were talking about the babies that are jaundiced? That's the reason that we put them under those UV lamps, is to help break down the bilirubin. So when we collect our bilirubin samples, we usually do them in a dark brown tube, and that's to help prevent that bilirubin being broken down from light. So here is the calculation to calculate our unconjugated bilirubin. Unconjugated bilirubin equals our total bilirubin minus our direct bilirubin. And here are our reference ranges for adults. The total bilirubin should be between 0.2 and 1.2 milligrams per deciliter. The conjugated bilirubin should be 0.1 to 0.4. Unconjugated bilirubin should be in the range of 0.2 to 0.8. So here's a question or a scenario. An MLT clinical student obtained the following results. You have a bilirubin of 1.0, a conjugated bilirubin of 0.8, and an unconjugated bilirubin of 0.7. What should the MLT student do next? Should they report out these results? Should they consider a recollect? What do you think? Take time to try to figure it out before you go on to the next slide and see the answer. So in this scenario or question, the total bilirubin does not add up correctly. In this situation, they add up to be more than the total. So a technical or instrumentation error has occurred. So you cannot report these results out. The issue must be resolved. So somewhere along the line, something has happened, so you cannot report these results out. So the total bilirubin that was given was 1.0. When you add up 0.8 and 0.7, you end up with 1.5. That should have been the total bilirubin. So something is not right here, so we cannot report these results out. Now let's talk about the urine test for bilirubin. The reagent strip or the dipstick for bilirubin reaction is based on a diazo reaction, and you're only going to see conjugated bilirubin show up in urine using the dipstick method. Now for your bilinogen in urine, it's an Ehrlich's reaction. The reagent is a para-dimethylaminobenzylaldehyde, and you can remember PDAB for short. The reagent strip cannot detect the absence of your bilinogen. We've talked about that in the past. Only if there's a normal amount or increase. Remember, the least amount that the urine dipstick can detect for your bilinogen is 0.2. It cannot detect 0. You will have an increase of your bilinogen in your urine and a prehepatic jaundice, and you'll also have increased rates of your bilinogen if a patient has hemolysis. We must often do blood tests to test for liver function. We test for serum enzymes that will rise when there is liver damage. We look for two different aminotransferases, the AST and the ALT. We look for ALP, alkaline phosphatase. We could also look at LD, lactate dehydrogenase, and finally GGT, gamma glutamyl transferase. These tests can be run individually, or they can be grouped into a panel, or a liver function test panel, or an LFT. Some of these are routinely measured in a CMP or a comprehensive metabolic panel. Other enzymes that may be in a liver function panel is our albumin. Remember, albumin's a protein or total protein, a PT, a prothrombin time, which is our coagulation test. So think back about hematology, a total bilirubin, or a direct or indirect bilirubin. Liver enzymes are released during cytolysis, which is when cells burst or release their contents, and necrosis. And remember, necrosis is cell or tissue death. There's marked elevation of AST and ALT in liver disease with hepatocyte damage, such as viral hepatitis. We have marked elevation of ALP in hepatobiliary disease or obstructive jaundice. And when we're talking about hepatobiliary, we're having to do with liver, bile ducts, or gallbladder. All three enzymes will be increased in liver disease, but we will see more markedly increased AST and ALT in hepatocellular disease, and marked increase in ALP in obstructive biliary conditions. So let's just take a minute and focus on our AST enzyme. It is clinically significant. Of course, it's used to evaluate liver function, but remember back when we were in our cardiac lecture, it used to be used as a cardiac enzyme because it can increase post-myocardial infarctions. AST will be increased in hepatocellular damage in our liver conditions such as viral hepatitis, cirrhosis, Rye syndrome, and alcoholic hepatitis. Now let's focus on ALT. Again, it's clinically significant. You'll see highest elevations in acute viral hepatitis and toxic hepatitis. You'll see modest increases in ALT in obstructive liver, in cancer, and cirrhosis. Often you will see increases in AST and ALT before a patient has any symptoms of liver disease, and these enzymes are included in your CMP or complete metabolic panels. Now let's discuss something called the de-Ritis ratio. It is a ratio where AST is put over ALT, and it's helpful in determining the cause of liver disease. The normal ratio is 0.7 to 1.4. In alcoholic liver disease and cirrhosis, you see AST is greater than ALT, thus the ratio is greater than 1. In viral hepatitis, obstructive liver disease, and acute inflammatory disease are associated with ALT is greater than AST, so it's the opposite. Thus you see a ratio of less than 1. ALP is present in most all body tissues. It's primarily richest in the cell membranes of the hepatocytes and osteoblasts in your bones. You will see marked increases of APL in Paget's disease, which is a chronic condition that causes bones to become deformed and weak. So we will see elevated ALP in liver and bone disease. Will also be increased in growing kids because the bones in children are still growing. ALP will be more increased in obstructive liver disease than our hepatocellular diseases. An example of results in patients with obstructive disease will be as follows, and an example might be a patient with gallstones. You will have ALP that's markedly increased, and your AST and ALP will only be slightly increased. So now that we've talked about each of the liver enzymes, let's look at some different scenarios and try to come up with the condition that the patient is suffering from. So we have a patient with liver enzyme results as followed. You have AST that's markedly increased. You have ALT that's marked increase. And then you have ALP that's only slightly increased. So which condition listed below is most likely? Is it viral hepatitis? Is it obstructive liver disease? Or is it bone disease? Try to figure out on your own before you go on and get the correct answer. Have you come up with your answer? The correct answer is A, viral hepatitis. This is because the damage to the hepatocytes is causing the AST and the ALT to be markedly increased. For obstructive liver disease, you would see a modest increase in ALT, not a marked. And for bone disease, we would see our ALP in higher levels. It wouldn't just be slightly increased, it would be marked increase in ALP. Let's look at this next scenario. We have patient Sheldon that is an adult male. He's 30 years old, and his results are as follows. The AST is normal, the ALT is normal, but the ALP is markedly increased. So the results best correlate with which condition below. Is it viral hepatitis? Is it obstructive liver disease? Or is it bone disease? Again, try to figure out on your own. Pause the video and then go on and get the correct answer. The correct answer is C, bone disease. If we have AST and ALP that are normal levels, then that only leaves the option of bone disease. Remember, ALP will be increased with liver disease and bone disease. Just a little bit more information about GGT. GGT is present in serum and all cells except muscle cells. Most serum activity is from the liver. Thus, the GGT can be used for our liver function test. It can be used in the detection of hepatobiliary disease or obstructive jaundice. Also, GGT can be used to detect injury caused by alcoholism or drug ingestion. It's the first liver enzyme to increase in liver damage from alcohol. So always think about this one and alcoholism, or being used to test patients that have a problem with alcoholism. Our silly little trick to remember GGT is to remember gur, like you're chugging or you're drinking. So let's look at another patient scenario. The lab results are as follows. The AST is mildly increased, the ALT is mildly increased, the ALP is markedly increased, and the GGT is markedly increased. So which condition below correlates best with these results? Again, we have our three options. We have viral hepatitis, obstructive liver disease, and bone disease. So pause the video and try to figure it out on your own before you go on and get the correct answer. The correct answer is B, obstructive liver disease. The last enzyme we're going to learn about is 5-NT, or 5-nucleotidase. It is useful along with ALP and GGT results when trying to determine if elevation is from the liver or the bone. It will be increased in liver disease. This enzyme is not typically in your liver panel. However, the provider can order after results of the liver panel is completed if necessary. Okay, this is our last scenario for this part of the lecture. A patient presents with increased unconjugated bilirubin, a normal serum ALP, a normal liver enzymes of AST and ALP, and no bilirubin in the urine. Okay, so with those lab results, what is the condition? Is it viral hepatitis? Is it chemical damage to the liver? Is it an increased rate of hemolysis, or is it obstruction of the common bile duct? Try to figure it out on your own before you go on in the video and see the correct answer. Do you have your answer? The correct answer is C, increased rate of hemolysis. We know just by the fact that the liver enzymes AST and ALT are normal that the liver function is normal. So right there we can eliminate viral hepatitis, right? But we have this increase in our unconjugated bilirubin, and that's because of there's going to be an increased rate of hemolysis. So that's our giveaway. So it's C, increased rate of hemolysis. This concludes part 2 of our liver lecture. I'll see you over in part 3. But if you have any questions or need further clarification, don't hesitate to reach out.